Okay, I'll just pull up the slides and we'll get a slow start. So again, good afternoon, everyone, and welcome. I really want to thank you for joining us today on our webinar on nurse prescribing Suboxone in First Nations community health settings. FNHA is very grateful to be co-hosting this webinar with an interdisciplinary team and other organizations like BC Centre on Substance Use, Okanagan Indian Band, and Musqueam, among others. So my name is Kate Hodgson. I'm a practice consultant for substance use on the Four Directions team, and I'm going to be facilitating the webinar today. And we will just do a roundtable of introductions of our facilitators, and then we'll hopefully our other facilitator will be on the call, and we can move forward with our land acknowledgement and opening prayer. Paula, would you like to introduce yourself?
Sure, thank you, Kate. Good afternoon, everyone. Thank you for joining us today. My name is Paula Tate. I'm Withdrawal Management. I'm the Indigenous Wellness Educator for the Four Directions Wellness Team with First Nations Health Authority. And I'm happy to be here. Thank you.
Karina?
Sure, thank you. Tan Che, Dishnakashone, Karina Chase. Hello, friends. I'm Karina Chase from the Métis Nation, and I am in a partnership manager position with First Nations Health Authority and the BC Centre on Substance Use. And super excited that we're here to do this presentation. So thank you.
Amber, next on my list.
Hi, my name is Amber Frost, and I'm a member of the Oregon Jack Creek Band, which is just outside of Ashcroft, BC. I think it's one of the smallest bands ever, but I have the pleasure and honor to work for the Okanagan Indian Band on the unceded traditional territory of the Silk people.
And Amanda?
Hi, everyone. I'm Amanda Giesler, and I lead our education work here at the BC Centre on Substance Use. And I'm a settler here on Musqueam, Squamish, and Tsleil-Waututh lands. Thanks for having me.
And Nicole?
Hi, everyone. My name is Nicole. I am the Education Project Coordinator at the BC Centre on Substance Use. Today, I am, sorry. Thank you.
Great. Is Doris, I can't see the whole list at the moment. I'm hoping.
I don't see her yet. She hasn't arrived. I wonder if we could just ask Paula to open us up in a good way. And then when Doris comes on, we can do an introduction.
Yeah, that's a great idea, Karina. I could definitely do that. Thank you. Yeah, I can do an opening prayer for our webinar. And the prayer I'd like to share is Wet'suwet'en prayer that was taught to me by my uncle Wigginostahl. That's his chief name, and his name is Victor Jim. And it's a shortened prayer for us to say in our meetings. So I'll pray in Wet'suwet'en, and I'll also pray in English. So thank you, and we could join in prayer. Urukai Zin Hanzu, Ella Zin Nawano Ninai, Noltain, Nolpetse, Nolskak, Nolkai, Not Noliesni, Sakya Habahonli. Creator, thank you for today, another day. Our brothers, our sisters, our children, our grandchildren, our parents, those who raised us, take care of them well. All my relations. Thank you.
That was beautiful. Thank you, Paula.
Thank you so much. We, when Elder Doris Fox joins our call, we'll be sure to have her introduce herself and say a few words So thanks. So our facilitation team, as you can see, has a broad array of expertise and comes from all corners of the province. So our team respectfully acknowledges each traditional territory of each nation that we're calling in from, and the stewardship of the land by the First Nations people since time immemorial of the lands we're calling from. So I know some of you have introduced yourselves in the chat. Please feel free to continue to introduce yourself, your roles, and feel free to use the chat as we move through the presentation. So this is just a quick activity to get us started. This is a map of BC, and yeah, just as I said in the chat, feel free to introduce the territory you're calling from. And I think we have annotate features as well. So we could also use annotate features if you can. So just a few housekeeping pieces. Okay, I think my keyboard is not working as well as I thought it was. Okay, so just to let everyone know that this session will be recorded. And feel free to have your cameras on or off. Please keep yourself muted during the presentation, so not to interrupt any of our speakers. And yeah, ask questions, put your hand up, use the chat as we move through the presentation. If you're wanting everyone to see your comments, just make sure the setting in the chat is labeled as everyone. And if you're wanting to message any panelists directly or anyone else, you're able to change that to send a private message. And this is the annotate features. So if you roll your mouse over the view options, an annotate drop-down menu should come down, and you're able to use a stamp, a text to engage in any way that you can. Also, feel free to use the reaction buttons if you're if you agree with something, if it's too fast, too slow, if whatever, any way to be interactive, we encourage in this presentation. Thanks, Sally. Yeah, if people want to practice using the annotate features, feel free to go ahead and do that. There's also a view mode, so whatever works best for you. If you see the PowerPoint is just a very small box on your screen, feel free to use the view points and find a screen that works best for you. We also have an additional feature called Slido, and I'll hand it over to Amanda to provide instructions around that.
Hi, yeah, thanks, Kate. So engaging with you all and having a place to ask your questions, but also in a really safe way, is really important to us in this webinar. So we've enabled our Slido feature for this webinar. And so I'm just going to put the link in the chat for you there. But if you want to visit slido.com in your browser, and all you have to do, and when that pulls up, is put 123 in the code. It's our own private question and answer screen, if you will. And your questions will be asked completely anonymously. The other part that we really love about using Slido is that you can vote on other people's questions. So if you really like something that you're seeing in Slido and you really want to make sure that we get to your question, give that a big old thumbs up, and we'll make sure that we address those ones first. But yeah, we hope that that's a nice, safe place. If you don't want to ask a question in the chat here, we'll be watching for those in Slido during the presentation, and we really encourage those questions. Thanks so much.
Thanks, Amanda. And so this is the list of our facilitators. I'm just going to give one more call out to Doris, if Doris was able to join the call. I don't think so. Okay. So these are our learning objectives for today, or the learning path that we're all going to go on. And the goals of today is for all of you as audience members by the end to be able to, which I'm sure you are all experts already, and we hope that you contribute to a discussion, but to recognize the impacts of stigma in First Nation communities and learn ways to reduce stigma and support community members who may be experiencing substance use. To also identify traditional wellness strategies and some medications that may be used or prescribed to care for people who experience opioid use. And lastly, is we're going to really dig into the role of community health nurses as nurse prescribers of Suboxone, and the roles that health centers can play in supporting community members who may be using opioids.
All right, so Tanshe, hi friends, Karina Chase here. So I'm just going to acknowledge before we start this audience activity that I am seated on the ancestral lands of the Kakite people here in New Westminster. So I'm really honored to be able to sit on this land and do this work with you this afternoon. So when we talk about stigma, we're really kind of diving into a huge, like one of the hugest barriers that people experience in accessing harm reduction supplies. And there's different types of stigma. We're going to go through that, but we're just we're trying to prompt and tease out some different labels and words, language that that are barriers. So we're going to ask you guys to put some language in the chat box about things that are harmful to hear for people who use substances. And while you do that, I'm just going to inform everyone that I am a person with lived experience, so I'm lending not only my professional lens, but also somebody that's experienced some deep-rooted like destruction, and stigma is so hard to measure and it's so hard to identify. So there is that person that receives that, and it's something that permeates within their being, and also it's so harmful that they will risk losing their life as opposed to getting help because of the stigma. And so we're going to talk about that. And I'm just going to see what we have in the chat box, see what, I don't really see any words. Let's see. Yeah, addict, dirty urine test. Yeah. Substance use versus abuse versus use. And even in my job title, I was talking to my administration, like, I'm an addictions care partnership manager. So addiction in itself has connotations. And so we'll be trying to unpack some of that. Clean and dirty, that's a big one. Junkie, alcoholic, well, things with O to specific, but I think that with Indigenous folks too, I mean, we're going to be unpacking like the layers of like colonization and how we got here. And so it's really important to separate those two as well. Next slide. What are some examples of destigmatizing language? You can type your answers in the chat box. People, yeah, with lived and living experience. Substance misuse. Using person in first language, exactly, putting the people first and start identifying like this real separateness. And we do this with all diseases, but with the disease of addiction, we don't get, people don't get asked the same questions as other people. The healing journey, yeah, healing pathways, exactly. In recovery, and in recovery, like that sometimes can have its own connotations if recovery means abstinence to people. Yeah, people with a condition. Yeah, exactly. All right, keep them coming. We encourage lots of interaction as Kate was talking, and thank you. So what is stigma? Stigma is defined as a mark of disgrace associated with a particular circumstance or quality of a person. The feeling of being othered and separating, isolating, dismissing. There's lots of like ways that people feel stigmatized. Stigma affects how we treat people. And I think what happens is, you know, there's this cause and effect. So here we know people are stigmatized, but once somebody else does that, and then it has like an alter effect where other people feel like it's acceptable to do that to people, and they forget that they are human beings. And for some people that are in late stages of substance use, it's really obvious that they're struggling, but there's all this judgment that comes from, I think, society, that they choose to be there. That's a choice. They did this. And so we're going to talk about how colonization played a huge role in disrupting people's well-being. Next slide, please. This is Paula. Paula, it's your slide.
Okay, the next one. Okay, so what are the drivers of stigma? So stigma is driven by stereotypes about people with substance use disorders. And there's a negative perception when that translates into negative attitudes that affects all level of care. In turn, the tend is to reinforce each other, ultimately hindering good health outcomes. And the legacy of colonization, the loss of language, and how culture is significantly impacted by Indigenous well-being. The individuals who use substance use may also have may face multiple systems and barriers, and these are not exclusive to healthcare system. It's also care, corrections, justice, policing. Often the individual experiences various stigmas, spanning structural stigma, social stigma, and internalized stigma. And this is my slide as well. So the historical perspective of the racialized stigma that Indigenous people continue to experience today comes back from our historical relationship with the government, where the government imposed the Indian Act on us that governs us even to this day. And that was created in 1876. And the purpose was to assimilate Indigenous people into Canadian society. So get rid of our culture, our language, our ways of being. That was the intention of the Indian Act. And it's also a paternalistic legislation where it puts the focus on men and women inferior. So that still exists today within the Indian Act. And it wasn't consulted with our ancestors, it was imposed upon us. And just to give an idea of one of the legislations that were against us with substances and with alcohol. This picture here is a notice that if our ancestors were caught with alcohol, consuming alcohol or having alcohol on their possession, they were fined $300. And $300 today is equivalent to $3,000. So imagine getting fined for some simple thing that is equivalent to $3,000. There's no fines that I know that cost this much except the COVID restrictions. That's all I could think of. So this was a great impediment that was on us. And the purpose of this legislation, this policy, was that the Canadian government did not want Indigenous to intermix with the rest of Canadian society with white people. They were trying to stop that from happening. That's the reasoning for this policy. So it was based on race.
So the types of stigma. So stigma is this multi-phenomenon. It's like I can self-stigmatize myself, and then while I do that, I feel unworthy. I don't maybe feel like I deserve to access harm reduction, and I go over to my doctor's office, and maybe I'm stigmatized while I'm in the office as being that person that's, who uses substances. I feel a little shameful. Maybe I'm a little weathered for wear, for worse. And then we have systemic structure. So some of the policies and surrounded not only around treatment and access to harm reduction also play a role in in stigmatizing people. And we really want to kind of tease out like languages for the sake of this. But we know that when people experience stigma and complex trauma, so it gets rooted in trauma and pain. So people are using because they're experiencing trauma, or they've experienced it, and they have pain, so they're self-medicating, and then they experience stigma, and probably within their own circles and ways of coping and managing, they're also in really vulnerable positions, and they can also be re-traumatized. So it's this ongoing system for them that they can't seem to get out of. And so when we're talking about this, we're really talking about trying to build relationships, because the opposite of trauma is connection. And so we're trying to really take that home here.
So the impacts of stigma, and the stigma contributes to the opioid crisis. And what the slide is saying is that stigma is driven by stereotypes about people with substance use disorders. And there's a negative perception then translates into negative attitudes that affect all level of care, and in turn reinforce each other, and ultimately hindering good health outcomes. And for example, there's less access to healthcare and harm reduction. There's lack of trust with healthcare services. There's feeling of self-shame and the sense of hopelessness and isolation. And there's also a lack of understanding from family and friends or others, and that fuels disconnection.
So stigma and harm reduction. So we can minimize moral judgments by educating and holding compassion. And it's really about connecting with people and asking them what they feel they need, and including them on their decisions, really supporting that self-determination with people. We can educate about what stigma is, and also we can start really being reflective in our own practices, and how I think we all do it. So it's not like about blaming, it's about understanding where we're coming from. If we've been indoctrinated into a stream of thinking, then how do we divert that thinking to be more helpful and more caring and supporting people? We want to talk about destigmatizing language, really diving deep on that personal views about injection drug users. Like if I talk to every person who I used with like 25 years ago, and I'm aging myself here, but a lot of people I don't think feel like they could have went back to school, or they could have carried on, and not just because of their own inner narrative. It's about who we surround ourselves with and who's connecting with us.
So it's everybody's responsibility. Reducing stigma requires a change in behaviors and attitudes towards acceptance, respect, equitable treatment of people with substance use, and reducing stigma and discrimination is critical to improve individuals' life, quality of life, but the health systems themselves. Substance use is not a matter of willpower, choice, morality, or a lack of willpower.
Yeah, so we all coming together to really unpacking some of the barriers, and we all have a role in eliminating and addressing that within our own scope of practice. Now, the thing with Indigenous people, we know that the Mary Ellen Turpel-Lafon report was out, and it's not only stigma, but it's also racism. And it's about having really constructive conversations about stigma and other barriers that we're presented with, and how do we dive deeper in that and do it in really helpful ways. Indigenous people continue to be overrepresented in the overdose and overdose deaths data. And next week, I know FNHA will be providing an overdose report, and so that's coming up. But when we talk about these things, we know that substance use disorder is about loss of culture, loss of family, loss of identity, or maybe people have just never been able to attach themselves to that. We know that children are overrepresented with MCFD and incarceration rates. So we do have a large a big job, you know, and it's like, it's about just maybe connecting with the people in your circle and letting them know how much they make a difference in your life and how important they are. So audience activity, thank you for turning that. I'm gonna invite Amber Frost, our amazing nurse from Vernon, to please.
Thank you, Karina. So Amber Frost, I'm the community health nurse from Okanagan Indian Band, and I'd like to introduce this next audience activity. Let's take some time to share knowledge from the audience. Again, if we could get everybody to think about ways that their local health centers in your own unique communities can participate in stigma reduction. So any thoughts or ideas, shoot them in the chat, write them down, and let's share everybody's thoughts on how you may be already doing it in your own health center and community setting. And some of the ways that, you know, I can think of would be, and the way we do Okanagan Indian Band is open door policy, person first care, person first language would be some of them, providing education and teaching. Does anybody else have any ideas? I can probably keep going. If anybody's kind of thought, yeah, so provide harm reduction programming, absolutely, yeah, harm reduction supplies, for sure participating in the not just naloxone training, encouraging members to like elder and youth as well, so that's getting everybody involved, low barrier access for sure. So it's all about having this open conversation and creating the safe space to have this open conversation. What I've learned, drop off naloxone kits at community health centers. When I've brought people together within the community before COVID, creating a safe space, there was a lot of knowledge sharing and teaching that went on. And we often can act as role models, right, to like ways we could reduce stigma. So I found that very helpful. Building relationships and trust, absolutely. Not just jumping to the work right away, taking time to sit and listen, absolutely. Harm reduction supplies, self-care supplies, traditional care packages for sure. Individual education. Sounds like you guys have lots of great ideas. So I'm glad this is being recorded, because, and are we going to record the chat? I hope so, because that's got a lot of really good ideas and ways we can bring the stigma reduction into our own communities. Thank you.
Thanks, everyone, and thank you, Amber. I would like to welcome Doris, Elder Doris Fox from Musqueam, to lead us through this next part of the presentation.
Hi, thank you. Sorry, I'm having troubles. I don't know if it's my internet or if it's the tablet, but as soon as I turn the video on, it goes all wonky and then disconnects me altogether. So I'm just going to leave that off for now. I just talking back to the last part of the workshop here, is that it's so important that we come from a place of love. If we aren't in a place of love, if we aren't thinking from our heart, not our head, it's so much easier to be kind and gentle and to trade places with a person and see how they're feeling about what's going on in their life. And as I said before, nobody starts off as a little kid saying, I think I'm going to be drug addicted or an alcoholic or whatever. And to see our dear family members as human beings. And I think the families that I've worked with have all, excuse me, said the difficulties they have are not knowing what to do and being so afraid their loved one is going to die from a drug overdose. And so what they do is they distance themselves because they just don't know where to go. They don't know what to do. So we need to find different ways of helping our families understand what's going on. And anyway, okay. Learning who you are and who your ancestors are. Yes, absolutely. It helps us to make a connection to our land and to our people if we at least know where we are, where we come from, because so many people in the city have never been to their home communities, have never had any connection or anything to do with their home communities. They don't even know who their families are in their home territory. And that disconnect is so harmful. It hurts deep in their heart. And so to this, I always say, but your ancestors know exactly who you are, and they know where you are, and they walk with you every day. And that seems to bring a little bit of comfort, I guess. It might not be everything that they're looking for, but it's a start. It's a good start to know, to let our dear loved ones who are in addiction know that they don't walk alone, that they have ancestors who watch out for them and do their best to take care of them. And if someone doesn't know even where they're from because of the 60 scoop and because of the old system of social services, how they would just automatically take the children away. I always say to pray to Great Spirit, ask him. To me, prayer is not a prayer as in religion. It's just having a conversation with the Great Spirit, with Creator. And ask, please put someone in my life who knows where I'm from or who knows somebody in my family. And invariably, the ones that I've worked with who have done that have been put in someone's path who happens to know who they are or where they come from. And that is so healing. And it's really helpful. It's really helpful to their heart and their traumas. I'm not saying that that's the be all end all solution, but it sure does help a lot. And I also say to those who don't know where they're from, is take up the traditions that are around, because they used to joke, the police and others used to joke and say that Vancouver was the biggest reserve in Canada because we have so many people from all over Turtle Island. And I mean all over Turtle Island. And even if you pick up a tradition that isn't from your homeland, it can spark memories, beautiful thoughts or good feelings that begin to help people heal and make them feel better. When I was teaching a class on Coast Salish, traditional Coast Salish weaving, all the ladies said, well, this isn't my tradition. I said, it doesn't matter. I'm just sharing from my tradition. And these are the people who taught me. So I talked about my grandma and my elder aunties. And before you knew it, everybody had a story from in their family. It triggered memories, beautiful, warm memories that lifted them up, helped them to understand that, hey, I do have a family. I do have loved ones. I do come from somewhere. And then we had one lady who, because of that and because of the ongoing conversations that we were having in the group, she actually remembered where she was from. And only because, not because of the weaving, but because of the conversations that went on around doing something traditional from Indigenous people. And it made her think of her aunties and her grandma, and eventually her mom, and she actually remembered where she was from and being a little girl on the land. Didn't remember when she was taken, but it helped her. And even though it didn't take her out of her addiction, it made her feel better in her heart. And to me, that's a good start. That's a really, really good start of helping somebody on their healing journey, because it is a journey. It's a lifelong journey, but we don't want to tell them that right away. We'll ease them into it as they go along. And the last one, understanding that people who experience substance use are more than the substance use. And that's what I've been saying and have been saying for a very long time, is that they're not the addiction. The pain that they've suffered, whether it has been handed down to them intergenerationally, or it's something that happened in their own particular life, is what leads people to addiction. Some people are lucky, like me, who had a huge, awesome support network that would never let me fall down. They were always there to, if I did trip, they were there to catch me and make sure I stood back up on my feet right away. And always telling me, always teaching me, telling me how awesome I was, and it was okay to be me, and all my weirdness and funnyosities, and I'm lucky I had that. Whether that was by luck or design, who knows? But not everybody has that. And that's what leads to our family members falling down. They don't have that support system in place. And even people who get into addiction, like a cousin of mine, he came to see me at work, and he came and sat down. I was answering the phones, and he came and he sat down beside me. And the rule was I wasn't allowed to have anybody sitting beside me while I was answering the phones. And the boss came up and looked at me, and I just frowned and shook my head at him like, no, go away. And my cousin talked to me, and he said, you know, you're the only one who loves me. I said, no, that's not true. I said, your mom and your dad love you. No, they're mad at me all the time, he said. They don't like that I take drugs and I drink too much. And I said, well, they don't know you the way I do. They don't see you the way I do. And he said, you're the only one who sees me, who really sees me. And you don't judge me because I take drugs or because I drink too much. And I said, well, that's okay. Isn't it nice to have one person in your life at least who loves you just because you're you? Not because you're in addiction or because you drink too much. Because you're you. You're my family. You're my blood. And I love you. Sure, I wish you'd quit taking drugs. I wish you wouldn't drink so much. But I still love you. And so for a few days, he would come every day about the same time and come and visit me. And then he said, I'm going downtown. I'm going downtown just to have one last party. And I begged him not to go. And he was starting to come out of the fog. That's the only way that I can describe it. because he was starting to feel the love that I had for him. And he started to see that other people in his life loved him. But he couldn't see that before because of the addiction. And even though I begged him not to go, he went anyway. And of course, we get a phone call in the middle of the night. He was found dead from fentanyl. And I thought, how sad that he finally got to see his family did care for him, his family did love him, and then he went home. And I think maybe if we can be more forgiving and more gentle, and like I say, come from that place of love, it might be a little bit easier for some to leave their addictions and walk away to a clean future. In the old ways, we always supported each other. When one was hurt, somebody would come and take up that person's work in the community to make sure that all the work was done. Things were worked out together as a community, but now we live in all these little boxes separate from each other instead of our traditional way, which was in big long houses. And I think that's maybe part of how come we're in the mess we're in, because we're so far removed from our traditional ways and our traditional way of living. And people laugh and they go, who would want to live in a longhouse with 1,000 people? And I go, well, I would. And, that removal from language, from traditions, from values, beliefs, culture, ceremonies. It's no wonder why our people are struggling so much. But we need to remember to come from our heart. Always come from your heart and love. It's really hard to mess up, make mistakes if you're coming from a place of love. Thank you.
Thank you, Doris. I know that was a very impactful part of the presentation, so I'll just even letting that settle with myself. So this part of the presentation, we're gonna speak about the medications that can be offered or prescribed for opiate use disorder. And when we talk about those medications, we refer to them as opiate agonist treatment or opiate agonist therapy. We use OAT for short. So just for reference as we move through the next part of the presentation. So OAT are medications that mimic other opioids, and they are very effective at providing people with relief from opioid withdrawal or opioid cravings. They can be used to treat opioid disorder and also other polysubstance use disorders where opioids might be used in conjunction with other substances as well. OAT is very effective at preventing both fatal and non-fatal overdose incidents. And increasing the access to these medications is a high priority of our team and work provincially being done in response to the overdose crisis. So when we talk about this class of medications called OAT, we are referring to mostly 3 medications in context of this webinar, and that's Methadone, Buprenorphine Naloxone, which is the trade name is Suboxone, and slow release oral morphine or SROM. So this depiction on the left of the cars is really comparing methadone to Suboxone. So methadone is the big, powerful car. It's a full agonist. It has a very long half-life. Generally, it only needs to be taken once a day. And it also provides like very good pain relief. And it has all that full activity on the opioid receptors, the mu receptors. It also acts on another receptor known as the NMDA, which is known to provide some of its beneficial effects as well. The other medication, buprenorphine, is the slower, the station wagon. It's also known as a partial agonist. So it doesn't have that full potent effect. However, it is very effective. And buprenorphine naloxone is a combination medication. So the active opioid is buprenorphine, which is less potent than the opioid and methadone. And the other medication is naloxone. However, when the medication is taken by mouth, the naloxone component doesn't have any effect. So the naloxone is really in it just to prevent diversion or to prevent someone from injecting the medication. And naloxone is the same medication that would be in like a take-home naloxone kit used either intramuscularly or intranasally. So the naloxone is just the puff of smoke because it really is the brakes. It causes opioid overdose reversal. So this is an image of the opioid continuum of care. People with opioid use disorder require different treatments at different points in the care continuum, and people may move to higher intensity or to lower intensity depending on where they're at. So we see the middle box is the agonist therapies, which is really the medications we're talking about today. And buprenorphine naloxone or Suboxone is the preferred first-line agent, and also methadone. And sometimes people are needing higher intensity support, where slow release or morphine generally lies for folks where Suboxone and methadone maybe weren't as effective. And those medications in the gray box are generally prescribed by a physician or addiction medicine specialist. If people are requiring less intensity and moving over to the recovery phase, we look at tapering off OAT. However, that's only with a lot of psychosocial supports, cultural supports, housing supports, because we know that withdrawal management alone is not a safe option at this time. At the bottom, you see harm reduction in philosophy and practice as an approach that's non-judgmental, that's culturally safe, and harm reduction is offered throughout the entire continuum of care. So in the context of nurse prescribing, what is new for nurse prescribers is the ability to diagnose a formal condition. So this is the first time that nurses have been able to make a formal diagnosis, and it is for opiate use disorder based on the DSM-5 criteria. So we used to use the DSM-4 criteria, and there's been a few slight changes. The biggest ones being that in the DSM-4, you only required one of these symptoms to make a diagnosis of mild substance use disorder, whereas now with the DSM-5, you do require 2 to 3 symptoms to make a diagnosis for mild substance use disorder. The DSM-5 also removed the symptom of issues with law enforcement as a symptom of a substance use disorder, because this is discriminatory and it's not reflective of a substance use condition. So just to reiterate, that detox or withdrawal management from opioids is not recommended. There is often people go into inpatient detox facilities, and this is really as a way for someone to stabilize and transition onto an opiate agonist therapy when we talk about opiate use disorder. So withdrawal management alone without opiate agonist therapy causes high rates of morbidity and mortality, including overdose, especially after a period of abstinence. It also increases the risk of other chronic disease transmission like HIV transmission, and also high rates of relapse to substance use. So Suboxone is a medication that nurses are now able to prescribe with specialty training, and Amanda will talk more about that. But Suboxone is a really beneficial medication. It has a great safety profile. It has a ceiling effect for respiratory depression. So at low doses, and people who are naive to Suboxone may have some sedation, but it really doesn't have that same risk of opioid depression like other opioids or even methadone or SROM. Suboxone, people, the traditional way of starting someone on Suboxone was that they would have to wait without using opioids for quite some time, and it would be uncomfortable. But now we have a microdosing induction method where people are still able to continue taking other opioids, whether illicit or prescribed, and slowly titrate onto Suboxone. So it makes that transition phase onto Suboxone much easier and more comfortable. And Suboxone is also a great option, especially for rural and remote communities, because it's a safer option. We're able to provide carries and support people having the medication at home much more readily than we would with other opioid medications. So here's just a few more advantages of Suboxone. It has that low risk of respiratory depression. In fact, there's much less than 1% of fatal overdose caused by Suboxone. It is a very safe medication. And less risk for diversion, can take it home more safely, and it has a milder side effect profile. Doesn't have the same side effects as methadone. And you are also able to titrate up to a therapeutic dose more quickly than other OAT options. So disadvantages of Suboxone is people do drop out of Suboxone treatment, or sometimes people don't retain very long on the medication. This is for a multitude of reasons, but we do have the other medications to look to if Suboxone isn't effective for a person. So that goes back to really looking at the patient's goals and having those ongoing open conversations with people. These are some briefly some common side effects of Suboxone. However, from our experience, it's tolerated quite well. Common side effects are headache, nausea, or upset stomach, dry mouth, and some sedation, but respiratory depression is very rare. When we look at treating someone for substance use, the medications are one part. However, looking at the social determinants of health and all the other aspects of a person's life are also exceptionally important. So we know that there are specific social determinants of health and health inequalities that are more common for people who live in rural and remote communities. This picture is not mine. It is our colleague, Jolene Pagaroot, who's doing some teaching in Prince George today and was unable to attend. But this really is an image that depicts some of those social determinants of health and barriers that people in rural communities are faced with to access a pharmacy or to access a prescriber for OAT. So this is an image in the northern region, and this road Jolene shares is actually on a good day. So there's many days where there's no road at all, and people are unable to get to pharmacies or to see doctors to get the healthcare that's required. So when we are supporting someone on OAT therapy, it really is the whole team's responsibility to support this person. It's so much more than taking a pill, and it's really rests on the importance and value of all team members, especially drug and alcohol counselors, traditional wellness workers, social workers, community health representatives. Every person is required to holistically support someone while they're taking OAT therapy. And that's why nurse prescribing is embedded in team-based care. It's important to keep an open mind and be innovative in meeting people where they're at in their healing journey. And for some people, those most impactful conversations happen when you're maybe doing activities that's not related to medication. I know Doris referred to as, cooking and doing a traditional activity. And I know for myself, working with people, it's really like sharing food, driving in a vehicle, and just being innovative in how we're approaching care. Innovation can occur in other ways too, like providing virtual visits, supporting a person to be able to have their medication at home more safely, and including friends and family as identified by the patient in the care planning, and providing friends and family education, and also maintaining strict confidentiality to ensure safety and trust is built with people. All right, we have our final audience activity, I believe. So now from what you've learned, thinking about your own role, use the chat and type in how can you and your role support a person with traditional wellness while being prescribed OAT therapy, or how can you support a person while they're prescribed OAT therapy in whatever role you are in. So even like going for a walk or providing more ceremonies for healing. Yes, connecting people to cultural teams and out of province people who need OAT therapy. That is, yeah, thank you for doing that, Sally. Inviting, oh, there's so many, this is great. Become better informed about local resources. Yes, great. Sharing traditional food. These are, yeah, really excellent suggestions. Thank you. Singing and drumming on Zoom. Yeah, that's a great innovative idea. And active listening. Thank you, everyone. I'm going to hand over to Amanda.
Thanks, Kate. That was a great summary of OAT. And just to say, well, OAT is not new at all. It's been around for a while for people with opioid use disorder. What is really new and exciting is nurses being able to prescribe Suboxone and hopefully other options soon. So we just wanted to cover how this happened and kind of the mechanisms that got put in place to do this important work. So the first one, if we go to the next slide, and most importantly, is that Dr. Bonnie Henry released a provincial health officer order. And so the language in here really enabled nurses to take a leading role in prescribing pharmacotherapy, or OAT, for people with opioid use disorder. And so we'll be covering a little bit of that mechanism and the education put in place to allow nurses to do this. But just to say is like, this really set the stage. This is nurses prescribing these medications was not in the standards, limits, and conditions before this time. It wasn't in their scope of practice. And so when this was initiated back in the fall, so we heard this announcement back in September, this really paved the way for us to be able to change those with the college and then create the education to support the nurses here at the BC Centre on Substance Use. So why is this important? I think you could probably guess these bullets yourself without me having to tell them to you, but having access to these medications that are very evidence-based, they've been proven to work, it will give us more access to opiate agonist treatment. So it would be no surprise to hear that nurses are really the ones helping to lead the way, especially in really rural and remote communities, where there's often not prescribers. So physicians or nurse practitioners, you'll find nursing stations. And so they're really well positioned and provide really great care. And so it seemed like a natural transition to be able to have nurses be able to provide this really important medication to people during an opiate crisis. And so we've acknowledged, the province acknowledges, the BCCSU, First Nations Health Authority, that the number of deaths happening as a result of this opiate crisis is entirely preventable and unacceptable. And so these are new measures being put in place and new processes that'll hopefully expand this access to people who really need access to these medications if they want them. And so, as I've already highlighted, nurses fill these really critical gaps in really rural and remote communities. We find nursing stations, very talented, caring nurses that can provide really good care for opioid use disorder. And this is just one way that we can enable nurses to continue doing their good work. And so just a little bit about the policies. I won't go down too much detail here, but just to say, once Dr. Bonnie Henry did that provincial health officer order, that's when the BC College of Nurses and Midwives were able to change their standards, limits, and conditions. And so that's the body that watches watches over the nurses and say what the nurses can or can't do. And so they changed their standards, limits, and conditions quite quickly in order to respond to this crisis. And then right away, the BC Centre on Substance Use, so my team was able to build this in our provincial opiate addiction treatment support program. And this is really important to be able to provide nurses really good education. I think about, having to manage dual public health emergencies. The nurses are really stepping up to provide so much vaccination and isolation support for patients, but then also being able to do this, opiate crisis work at the same time. And so our role at the BC Centre on Substance Use was to make sure we could provide the best education possible, to make it easier for the nurses and to make sure that they felt really supported. And so I guess I'll just take a moment quickly to acknowledge the nurses. I see a ton of nurses joining us today, just to thank you for just like an incredible amount of work this year. And for those of you that are thinking about doing nurse prescribing or have already signed up to do it, just a huge thank you. Just truly heroes of the healthcare system. And I have star eyes when I think about nurses and just the critical role you play in these communities. So thank you, thank you, thank you. And just my last comment here on the education pathway is that, while they do have, just back one slide. The online course. So we provide a lot of the foundations to learn about these medications and how to diagnose opioid use disorder. We also provide opportunities for them to practice their prescribing in a workbook and see cases. But then really importantly, we provide time to do an in-person preceptorship. So all the nurses doing nurse prescribing get to spend time with an addiction medicine expert to see real cases, ask their questions, talk about the trickier scenarios. And so just to say that the education program is really thoughtful, and that we want to make sure that the nurses are really well supported, and that we can see nothing but success coming from this new initiative that we think is really important and life-saving for people in British Columbia. And lastly, if you haven't heard about this already, we provide a 24/7 addiction medicine support line here through the BCCSU. So if you're a clinician, either a physician, nurse practitioner, nurse, midwife, or a pharmacist, at any time, if you have a question about addiction medicine, or if you have a patient or a tricky scenario, you are more than welcome and highly encouraged to call this number here on the screen. This is just another way to make sure that the folks doing this work, again, in really rural and remote communities that often can feel alone or isolated in this work, have someone else that they can call to get a little bit more guidance and support. So we're really glad that this nurse prescribing initiative can be paired with a really supportive 24/7 telephone line. And I think I'm passing it back to you, Kate, or maybe Amber.
It's over to me now. Thank you for that, Amanda. So I'm going to talk now, just getting a little bit more focused on, so what is nurse prescribing in communities? What does it look like? So let's go through it together, and we'll speak to a few of its components. So as Amanda talked about, we have a nurse who has completed additional education and training in the areas of trauma-informed care, as well as the education that she spoke to, with the ultimate purpose is to how do we support someone who has experienced substance use. So after somebody has completed the specific training and education, the goal for them is to be able to assess, diagnose, and prescribe opioid agonist therapy medications such as Suboxone, to manage and support and refer when necessary the person to achieve better health outcomes and prevent harms. So a nurse obviously can do this independently, given that they stay within their scope of practice outlined by the BCCSU. When a person experiencing substance use goes beyond, like when you work with somebody who goes beyond that scope of practice, then that's when referral to a higher level of care is completed, such as a referral to a physician or nurse practitioner. This can also be done at any time that the person requests. Once a nurse is working with a client and assisting in maintaining them on Suboxone, the goal would be to support and manage that person to continue on the opioid agonist therapy. This is done to limit any interruptions in therapeutic therapy. As we know, this provides best health outcomes, so we want to get them on the Suboxone, support and maintain them on the Suboxone. Of course, the person is always free to make their own informed choice and change their mind and stop. So we have to allow room for that. if at that point a person decides that they don't want to be on something like Suboxone anymore, then we would shift roles just a little bit, and we would support the person in harm reduction from that point while they have their continued, substance use. Additionally, nurses prescribe. Also, like the prescribing component also includes being in access to cultural supports and traditional wellnesses as well. And in the next couple of slides, we'll go through that a little bit more, but that's kind of, in summary, a little bit about what nurse prescribing communities may look like. Can we go to the next slide? And so, as I mentioned before, I'm the community health nurse from Okanagan Indian Band, and we are in the process of implementing our own opioid agonist therapy or nurse prescribing program. So I'm going to talk a little bit about what we're doing and share some of that with you. So OKIB OAT program is in the process of developing and implementing an OAT framework and a program that's focused on being inclusive of the following components and criteria. So number one in the middle is the client, of course, and around the client is the community. So this program will be community or client and then community focused. The rest of the diagrams and the circles and squares represent the additional teams in this program to make OKIB's OAT program team-based. This is done to provide that wraparound care for the individual using substances and for the community for which they are part of. Additionally, OKIB is also growing and developing a health center that is expanding service provision. So, for example, we are implementing a primary care clinic that has doctors on site. So that's something we're also doing, which is great because it supports any opioid agonist therapy or nurse prescribing program that we have. So this is a benefit for those who use substances, because within one health center and within their own community, the individual can access several resources that can assist them in maintaining, promoting, and improving the individual's overall health and wellness. This diagram represents a model of that care and includes the following teams. So let's speak to the teams now. So of course, we have the RN prescriber, and we've already covered that in detail. Additionally, we have a harm reduction team, which consists of a community peer support worker as well as a community outreach worker. We have a wellness team, which consists of counselors, alcohol and drug workers, social workers, family and child support workers. We have the primary care clinic that I was just talking about that has physicians as well as a medical office assistant. And then in progress, something else that we're building that would help support that wraparound care, complete care, is a sexual health clinic. And so that would be run by a registered nurse certified in sexually transmitted infection or contraceptive management. It's important to mention additional partnerships as well with allied healthcare professionals and organizations as it serves to strengthen and improve the client and community service provision for those who use substances. So speaking to some of ours, and so we shouldn't forget about our outside partners that can help and support us to support our client and community. So if the client has their own family physician outside of the Okanagan Indian Band Primary Care Clinic, don't forget about your regional health authorities. So here in Vernon, BC, our regional health authority is the Interior Health Authority. So we have a downtown primary care clinic. We have mental health and substance use services. We have a Camille Lefleur street outreach program, which does a lot of harm reduction in the area. We also know that a lot of our members are off reserve, but more than half of our members are off reserve and living in Vernon. So accessing off reserve, this is all the programs that they could access and we could support them off reserve. They also have an opioid agonist therapy clinic or an OAT clinic. They have OAT prescribing doctors. They also have their own Interior Health Authority nurse prescriber. They have a Suboxone nurse, which just supports people on Suboxone, as well as a substance use outreach services, overdose prevention services, overdose and supervised safe consumption sites, and facility-based treatment. So those are our residential alcohol and drug treatment centers. Okanagan Indian Band on Okanagan Indian Band Badlands have Round Lake Treatment Center and support recovery beds as well. And of course, we don't want to forget FNHA, so the Four Directions team, as well as your virtual substance use and psychiatry services. So we can go to the next slide. So nurse prescribing wise practices. So how to best support a person coming to the health center for information about harm reduction use. So like, how do we best support someone who comes to OKIB Health for information and accessing services with respect to harm reduction or substance use? There's a few ways that I think would be really beneficial, and so we're actively trying to create those within our own program here at Okanagan Indian Band. So the first is allowing multiple ways of access to the program. So this is how a person first engages and enters into the program, right? Because we know that there are many ways to do that. So they can directly access the program by calling or coming into the health center, or they can access the program through other referrals through other departments and other staff that we have here. So such as our wellness team, our harm reduction team, our primary care team, our other nursing services team, through the Interior Health Authority's referral and their teams, also through the client's family doctors or nurse practitioners, as well as local drug and alcohol treatment programs and facilities. In saying all of this, it is really important for us to ensure success of this program is that we need our referral sources and our partners to know what the program is. So having a good understanding of the RN prescribing or program here at Okanagan Indian Band. So all teams should have a good understanding of what the program is, what the role of the program is, so services that are being offered and the benefits of the program. Know how the clients can access the program. So what is the referral process? Is it clearly understood and easy to access and complete? And there should be good communication within and between the teams. So having formalized processes to meet regularly and stay connected. So essentially one of the steps I would like to do in the future is share the program with the different resources. So make sure the Interior Health Authority knows about this, make sure that Round Lake Treatment Center knows about this, stuff like that. Another way is to allow multiple ways to connect and communicate and engage with the client. So it doesn't have to be the standard process where you come in and we book an appointment and we talk. So clinic visits, of course, could be done, but also thinking outside the box. So possibly extending hours to improve access. There's a lot less people in the building in the hours, and people like that. It's privacy and confidentiality. Or if it's, doing home visits or community visits. So meeting in a place where they feel more comfortable and they feel more safe, doing it up by telephone or doing it by Zoom. Another piece is client-focused care. So meeting the client where the client is. And this is that concept that we participate with the client and walk alongside the client in their wellness journey. To do this effectively, we need to be understanding of the client. We need to know who they are, what they may be doing, what their goals and hopes are, what they think will work best for them, what they see as their strengths and their challenges, and what supports and resources they have available to them and how they access them. This is ultimately what client-focused care is, and it emphasizes the fact that all clients are on this wellness spectrum, and we need to ask the client and see where the client is and meet them where they are at. The fourth point is that intertwined in all of this process is building relationships, and it's important to note a few things about that. So know that it takes time and it will be at the person's pace. Know that it takes us being open, available, and understanding, and know that it will only happen when the person will allow us for it to happen. And lastly, is client and community care. So knowing the community at which you work in and at which the client resides in. And this allows us to acknowledge additional supports within the communities that we can offer to our clients. And such things could include, but definitely are not limited to, supports, and so referring and connecting to elders in community. Okanagan Indian Band does have one elder that we've approached, and she is partnering with us, and this is a really great thing. We also have a cultural team here, so connecting our members with the cultural activities going on. We have a social development team, which helps with anything that they may be struggling with. That social development can help. We also have a public health safety team, for example. Yeah, And so I hope that provided kind of a really quick overview on what we're kind of doing. It's going to be a great program, and I'm really looking forward to implementing it. And thank you for letting me share with you what the work that we've done so far.
Thanks, Amber, so much. I just see we have about 8 minutes left. I welcome Doris just to close us in a good way, and then we'll hopefully have a few minutes for questions.
You want me to do the closing now? Before the questions?
We can do the questions now.
Yeah, I'm happy to ask a couple questions. We've got two. It's a two-part question. And the first one, I'll actually direct it to Corinna if you're still there. Corinna, the question for you, if you could answer this one. It says, regarding connection and addressing stigma, would it be a good idea for those who will not engage for a recovery worker to go to them?
Yeah, I think that's a really great question. If they're not engaging with the health center, the community health center, I think outreach is definitely a place to go. And also, where are they going? I think always meeting them in a place that they feel safety in. So if they usually go and hang out at a certain area, I would start off with providing some harm reduction supplies and conversation, like, hey, how's it going? And, you know, and I think those are the initial steps. And then slowly with somebody with an outreach worker, they'll have the skills to use motivational interviewing and support some of that the dialogue if they're in pre-contemplation or whatever it is. So thank you.
Thanks, Corinna. Okay, second part to the question, and Amber, I'll direct this question to you. It says, for communities, what are some strategies to engage the community, especially during COVID? What are some strategies to gain trust from the community?
So good question. So strategies to engage the community. It's difficult during COVID, but we have found some ways to do that. So I really believe that making having this conversation and making it comfortable, so having it in all sorts of venues and stuff like that. So some of the things that we have done is if they're promoting something else, then I'm there too. I'm quietly there to approachable. I'll have some resources out and stuff like that. And I've built trusting relationships within my own community. So people will come over to me and they'll just start talking, and then I'll just, kind of show them what I have a little bit. And then so that way, so kind of tagging on to other programs too. So say like one evening we had we were providing a meal, and how they did that was a long kind of drive up, pick up your meal, and I was standing out there. And when they would get their meals, I would just kind of quickly say hello to them. So that's one. So really big right now is tagging onto other programs that we have running at the moment, and educating my other teams, so the cultural team, so making sure they know what I'm doing. And if they're giving out a resource, how can I give out a little resource too, right? Having different of my resources easily displayed at the health center. So I also provide all the immunizations and stuff like that. So in my immunization room is a poster, is cards, is handouts, is naloxone kits. They're easily seen and accessible, and we have a few of those throughout the health center. Those are just some of the ideas. Before COVID, we did have like a meal and a discussion, and we invited people to come and kind of do a roundtable talk. We could do that too with Zoom. We could have a roundtable talk and provide meals in that drive-up fashion. Everybody picks up their meals, goes home, signs up. That has worked in community, and then we eat and we share our meal over Zoom. I hope that provides with some good tips.
Super practical tips. Thanks, Amber. That was awesome. We'll do one more question, and Kate, I'll direct this one to you. Lucky you get to be last. Do you think that this will fall into the home nursing care role, or mainly will it be falling under the community health nursing roles in FNHA?
Yeah, so thanks for that question. So we know that in our smaller communities that Often there may only be 1 or 2 nurses, and each of them may have a different role. Like there may be a home care nurse and then a community health nurse. So really we're looking at teams that are able to be innovative and work together. So looking at nurses from all types of roles, and not necessarily needing to have expertise in substance use care or a ton of experience in substance use care. We are really prepared to support nurses in being prepared to be nurse prescribers. So in short, yes, we're looking at nurses from all roles.
That's awesome. All right, I think we're ready to pass it over to you, Elder Doris, for our final closing remarks.
Okay, thank you. Whew. Wow, that was very fast paced with a lot of information, and I feel like my head is kind of swimming from all the information, but it's a good kind of swimming. It feels good to know so many people are doing the same kind of work in their own way, and that gives me hope for the future. It really does. So I raise my hands in gratitude to each one of you for doing this good work, and looking to find more and better ways to help those that are in desperate need of being helped, if that's what they want. Great Spirit, we give our thanks to you for this beautiful day, for letting us have this incredible circle with so many wonderful minds and kind hearts, so much intelligence, and coming from a place of love. We raise our hands in gratitude to you for providing this beautiful circle so that we could get to know each other too and find more and better ways. We raise our hands in gratitude for providing this beautiful and wonderful day and allowing us, most of us, to work from home. It's hard not to be together, to be in person. We can't touch and connect and hug like we normally would. That's okay. We have Zoom and we can still see each other's beautiful faces and smiles and hear each other's laughs. I ask, Great Spirit, that you give each one of us more patience, courage, and strength to help deal with those who are becoming depressed from the length of this COVID business. I find that so many are becoming sad and saying, well, it's been a year. Why isn't it over? Help us to know and understand that this could take another 1 to 2 years before we're completely out of this. Help us to remember that it is each one of our responsibilities to lift each other up and hold each other when we trip and fall, so that we can continue to do your good works in your name. I personally thank each one of you for doing the work that you do. And I ask that Creator protect you from all harm, including the harm we do to ourselves. So everybody have a really great day and enjoy the rest of your day. Thank you so much, everybody. Bye for now.
Thank you, Elder Doris. Thanks everyone for joining. We'll leave it there and have a great rest of your day. Bye.